Alrighty. Welcome everyone to the ACP Long COVID Interest Group. My name is Nicholas Franco, and I help coordinate this group along with Dr. Anita Chopra. A couple quick reminders before today's talk. All of our recordings can be found on our YouTube channel if you are interested in past talks. And as we have in weeks past, we are doing a survey, and we would really appreciate if everyone has the time to quickly fill out one of these surveys before our talk today and one after. It should be about 5 questions and hopefully is very quick. So thank you in advance to everyone who's done that. With that, I will turn it over to Dr. Chopra to introduce our guest for today.
Thank you, Nick. I'm Anita Chopra. I'm an internist at the University of Washington and one of the physicians at the Long COVID Clinic as well. And I'm so excited today because I've been trying to bring Michael to this group for a long time now. Dr. Michael Mueller is an assistant professor of medicine in the Division of General Internal Medicine at Mayo Clinic. He practices internal medicine as well as integrative medicine and is a long COVID expert. He currently serves as the co-director of medical grand rounds for the Mayo Clinic and also serves as the section head for integrative medicine. Michael is very passionate about peer education, and I know that his insights into managing long COVID are always so valuable to all of us long COVID, physicians. And he is probably one of the most listened to voice in managing not only long COVID but also other post infectious conditions. Welcome, Michael.
Thank you so much for having me, and it's a great honor to be here. Very happy to be here.
Thank you, Michael. Today, I really, I'm very excited that you will be bringing in a whole sort of 360-degree view of the management strategies that are available to us, not only as an internist, but also using integrative medicine approaches. And I really hope that people here today can benefit out of these. Michael, I just want to start when a new patient with long COVID, or I want to emphasize any other post-infectious condition or chronic fatiguing condition comes in, perhaps with overlap of chronic fatigue and dysautonomia kind of picture. How do you approach integrative care? What are some foundational interventions that you would do most often, regardless of which symptom cluster there is?
So honestly, the very, very first thing that I can recommend is validation for patients. I cannot, or I try not to leave a visit without telling patients, this is absolutely real. You are not crazy. We absolutely see you. We hear you. We know you're struggling, and we're here because we'd love to help. I think that that validation is an incredibly powerful and an incredibly important thing for patients. Many of the patients that I've seen, and a lot of long COVID patients that I've seen, were patients with other complex chronic illnesses such as ME/CFS, fibromyalgia, POTS. I struggle with that, I think. And I think that part of the challenge is that many patients have had experiences with the medical system in which they have felt like they're going crazy. Like they feel like they don't, or they feel like there's not really an explanation, or like the physicians that they've seen have not been able to help them. So I think that honestly, before we even get into sort of the integrative and lifestyle things, the very, very first thing that I do is make sure that patients understand this is absolutely real. This is absolutely significant. We absolutely know you are struggling. So honestly, if there's nothing else you do with patients, do that. Is actually one of the, or I actually find that not only is that validation really, really important to make sure that patients are seen and heard, I think that that's actually a really important therapeutic maneuver as well. I think that patients really, really need to hear that. So that I think is honestly one of the first things that I can say is validation is incredibly important. The next thing I think focuses on, I think, general lifestyle changes, and some of this is somewhat contingent on phenotype. You know, while long COVID can take many different shapes and forms, I oftentimes will see patients who are either sort of struggling with post-exertional malaise, or I might see patients who are struggling more with sort of an autonomic, sort of dysautonomic tachycardia symptoms, or the static intolerance, lightheadedness upon standing. And oftentimes I will help to sort of, or I will try to target my or some of the lifestyle interventions that I do to those phenotypes. In general, one of the things that I find is very common is that patients often feel like they are in a state of emergency. They feel like they're in survival mode. They feel like they're in crisis mode. They feel like they are always in fight or flight. They often feel like they are tired but wired, like they're exhausted, but even though they're exhausted, they can't get themselves down to rest. It's like it's like their brains keep churning and they can't physically get down. And it feels like they have an old smartphone battery sometimes in their brain. Like that frontal lobe, that part of their brain that's really important for executive function, just isn't online and just doesn't seem to be working in the way that it used to work for them. And so I think that some of the foundational things I think about, sleep hygiene is helpful, I think, for pretty much everyone. So we talk about some of the non-pharmacologic sort of basics of sleep hygiene, making sure that your room is quiet and dark, making sure that you're doing relaxing sort of things before sleep, avoiding caffeine before bedtime, making sure that you're not using screens in the bedroom. Things like that can be incredibly important. I think that things like getting into a routine and just sort of developing sort of a routine, like for your day-to-day sort of life, can often be very, very helpful. And for many patients, I think that even in patients who don't struggle with post-exertional malaise, I think pacing is an incredibly important thing. And I think that making sure that you don't overdo it and making sure that you avoid crashes is an incredibly important factor. So I would say validation is probably most important. I think sleep hygiene is definitely up there. And then I think that also working on pacing is a very, very important part for the vast majority, I would say, of long COVID patients.
So, this is very helpful. I really want to emphasize that non-restorative sleep or unrefreshing sleep is one of the hallmarks of post-exertional of chronic fatigue. And so is, and post-exertional malaise can be an entity in itself, or it can be a part of the chronic fatigue syndrome. And addressing sleep is one of the pillars of managing chronic fatigue. And this can be any chronic fatiguing illness. It is also one of the pillars of managing brain fog. And Michael, you mentioned pacing, and we will talk about that in our subsequent questions as well. But pacing is best explained as using your energy envelope wisely and not overdoing things, avoiding the push crash cycle, and just going in the mode of conserving energy and not extending yourself beyond that threshold where you will end up crashing and being in bed for the next couple of days. Thank you so much, Michael, for this. Just really just laying out these pillars of care, especially in the first visit. Over to Nick for the next question.
Sure. So I think since it is such a common and important piece of care, I'm wondering if you have any specific things that you have found that have worked well for your patients when it comes to pacing. And that could be in terms of folks with fatigue, post-exertional malaise, or just kind of generally. But what have you found works well for you?
Yeah, so I think that one of the things, so the way that I often describe it to patients, fatigue and sort of post-exertional malaise is almost that, it's like your energy envelope was this when you sort of before COVID. The challenge now is that your energy envelope is smaller than it used to be. And the bigger challenge, I think, oftentimes for patients is that energy envelopes are not static. What your energy envelope looked like on Monday is not going to be the same as when it was on Tuesday. It's not going to be the same as it is on Wednesday. Even if you're pacing, even if you're doing kind of all of the things that you need to do in terms, or in terms of pacing. the American Association of Physical Medicine and Rehabilitation has sort of an acronym: planning, pacing, prioritizing, and positioning. So the 4P sort of, or like, sort of 4P acronym. P, the planning, I think is really important. Just making sure that you're planning out your days. Like planning out, it's almost like budgeting. And that's actually the analogy that I make for patients sometimes is, how we make a monthly budget, like, to make sure that we have enough money sort of at the end of the month. You can think about your energy envelope in the same way. You need to budget to make sure that you have energy to do the things that you need and want to do in a day. Pacing, making sure that you're not overdoing it. I think one of the challenges that a lot of patients run into is that symptoms wax and wane. And I think that many of my patients have reported that they kind of struggle with their good days counterintuitively, because on a good day you feel amazing. You want to do all the things, especially if you haven't felt well for a really long period of time. So what happens? You go out, you do all the things, and you crash, and then you're back, and then you're set back for a couple of days. So I think that making sure that you're really pacing, even on a good day, is really, really important. Prioritizing, making sure you know what's important to you and what are the big things that we need to get done in sort of a day. And then positioning, I think being recumbent often helps patients, particularly measuring and sort of preserving their energy envelope. It's okay to give yourself little 5-10 minute breaks throughout the day, or longer if you need that, to kind of, allow your body to recharge a little bit and then come back up. I usually don't recommend sort of the 2, 3, 4 hour nap, because that can sometimes disrupt your sleep architecture. But pacing and taking a little bit of time during the day, and if that needs to be recumbent, and even if you need to take a small nap, I think that that's understandable. And I think that it's important for patients to give themselves grace to do that, and to make sure that they feel comfortable and empowered to do that during the course of their days. The other thing that I sometimes find is helpful for some patients are actually wearables. Just to give you sort of an example, I wear a Garmin Phoenix Watch, and it has this body battery function on it, and it's pretty consistent actually. When I'm feeling more run down, it tells me that my body battery's at like a 7. When I'm feeling really good, it tells me my body battery's at like 65. There's also another band called the Visible Band. There's nothing magical about any of these companies. I think anything that just has sort of an energy monitor, sort of pace points, body battery sort of analogy can be really helpful. And the utility of that is that I think it helps folks with A, planning; B, it definitely helps with the pacing throughout the course of the day; and C, I also use or tell folks to, try and pay attention to how different medications, how different supplements, if we're trying them, or how different activities relate to what their energy envelope sort of looks like. If they're finding that there are some activities that are more fatiguing, if they're finding that there are some medications that seem to work a little bit more effectively and seem to be giving them more of or a bigger energy envelope, that's great data, and it helps patients to kind of know themselves a little bit better. So I'm a big fan of pacing, I think pacing, I think using the energy envelope analogy, budgeting your energy is really important. And then sometimes in many patients, using a wearable can be really helpful.
So those are really very concrete steps. Pacing, of course, which the providers can, physicians or primary care physicians can counsel patients. Wearables can help them keep they can know their heart rate, the number of steps they've achieved in a day, and what causes them to get pushed over the cliff and go into a crash. And wearables can also help them avoid having their heart rate go up. And in addition, physical therapy as well. Um, Michael, do you use any other non-pharmacological, maybe supplements, or all those strategies for fatiguing illnesses?
So it depends, is sort of the short answer. One of the better studied supplements out there is oxaloacetate. Oxaloacetate is one of the cofactors in the Krebs cycle. And I think that there was a small study in ME/CFS that suggested that, or treating at, I think, 1,000 milligrams BID, or even increasing to 1,000 milligrams TID, reduced fatigue by, I think, anywhere from about 25 to 33%. So I think that that's something that is worth considering. In some patients, you can consider using things like you can consider using coenzyme Q10. I personally have not seen that much benefit from it, but I don't stop it if patients are on it. One of the things that I have seen patients benefit from significantly is low-dose naltrexone. It's not necessarily a supplement per se, so I don't know if we're going to get there. But basically the thought process is that naltrexone is this medication that we've been using for decades for alcohol and opiate dependence, but at less than a tenth of that dose, 4.5 milligrams, there are potential anti-inflammatory effects. There are potential effects on what are called the microglial cells in the brain, which may actually help to decrease fatigue. And I would say that a decent, probably majority of patients I have put on low-dose naltrexone eventually get some improvement in their fatigue symptoms or their brain fog symptoms. It doesn't work for everybody. In terms of monitoring, I will usually tell folks to get a CMP a couple of weeks afterwards. I also caution folks that you need to have a compounding pharmacy in order to prescribe low-dose naltrexone. So it's not a commercially available dose. And the other thing that I also caution folks is that oftentimes this is a medication that doesn't work immediately. It's not a medicine that you're going to take and feel great the next day. There may even be a breaking in period for a couple of days where you feel almost even a little bit worse, a little bit more in terms of vivid dreams or headache or nausea. But in many patients, those symptoms get better after a couple of days, and then we do see some improvement. So for fatigue, I'm a very big fan of low-dose naltrexone. I have used oxaloacetate in the past. I think coenzyme Q10 is not an unreasonable thing to consider in the right patient.
Michael, I wanted you to, let's talk a little bit about these three things that you mentioned. Oxaloacetate, do patients find it very expensive? Again, I want to underline the fact that these are not evidence-based treatments yet. The low-dose naltrexone is being studied. There are trials going on, including by Recover. And, but, people who have tried, the long COVID specialists who have tried this medicine around the country, there is benefit reported. But oxaloacetate is a supplement. And do you find that patients report it is very expensive? That's been my experience.
Unfortunately, it is relatively expensive. So the challenge with oxaloacetate is really obtaining oxaloacetate. And the challenge is sort of multifactorial. One, it's really not super easy to find over the counter, like in your supplement stores. Oftentimes you're like I've had patients tell me that they need to sort of order it online. The other challenge is price and cost. And it can be, I think, I don't remember exactly off the top of my head how much oxaloacetate costs, but I mean, it is something that, if you're sourcing it, can be to like $100 a month or so. So it is a more expensive supplement. I've had some patients who have told me they've gotten a little bit of benefit. I personally am more of a low-dose naltrexone guy in terms of the first thing that I will try with patients. But it is something that it is something that I think about from a supplement perspective.
Thank you. And the low dose naltrexone is a compounded medication, and we can share with the group, Nick, later on, we can share a link with people on we have a smart set on how to, compound it, how is it dosed and how they go up. You start very small and you can go up on the dose. And every 2 weeks, you can escalate the dose depending on how patients are responding. Michael, I want to switch gears and jump on to something which is can be often very difficult to manage, which is dysautonomia. Dysautonomia is I would call it often like almost like a beast that overlaps with other conditions. It overlaps with brain fog, it overlaps with fatiguing illness, And it is not unique to long COVID. It can be a separate entity in itself presenting after any post infectious illness or coupled with any other chronic illness. Let's talk a little bit about dysautonomia. How do patients present, and how can you lead us through the diagnostic and management pathway, please? Thank you.
So when we think about dysautonomia, I think that one of the conditions that folks talk about is postural orthostatic tachycardia syndrome, or POTS. And many patients with post-COVID or with long COVID will often meet the diagnostic criteria for POTS. POTS basically is defined as a condition in which your symptoms are postural in nature. So you get symptoms when you go from laying to sitting or sitting to standing. You get orthostasis or orthostasis, so lightheadedness with that change in position. And then you get tachycardia, which is usually classically defined as greater than 30 beats per minute in adults or greater than 40 beats per minute in adolescents, and an increase in heart rate without a concomitant change in blood pressure. Many patients with long COVID who describe dysautonomic symptoms may meet some of these diagnostic criteria. And how do you sort of test that? One of the things that you can do is, well, the super sophisticated thing, if you have access to a tilt table test or an autonomic reflex screen, you can certainly do that. And that's considered sort of the quote unquote gold standard. But NASA lean tests and active stand tests, which you can easily do in the office and essentially are sort of like protocolized orthostatic vital signs, can help you to make that diagnosis and check that. That being said, not all patients with long COVID who have dysautonomia have POTS. Maybe you have a patient, for example, whose heart rate only went up 20 or 25 beats per minute. That doesn't necessarily mean that they may not have dysautonomic symptoms. The way that I sort of think about dysautonomia is you sort of think about the body, or I think about the autonomic nervous system as the body's autopilot. It's that part of your body that controls things like breathing, heart rate, blood pressure, things we don't want to have to think about to do. And I think about dysautonomia particularly as a hyper or in long COVID as most commonly sympathetic hyperactivity or sort of a hyperadrenergic state. It's not a perfect analogy, but for some patients, I will almost make the analogy of if you've ever seen Scooby-Doo and you see what Scooby and Shaggy look like when they see ghosts. That's actually not too dissimilar to some of the changes that you can see in post-COVID or long COVID dysautonomia. What are Scooby and Shaggy doing? Their heart is pounding. It's beating really fast. And so and it's beating really, really hard. That's part of that sympathetic hyperactivity. That tachycardia can even lead to that orthostatic intolerance. So lightheadedness upon standing. Autonomic nervous system is important in controlling breathing. And so sometimes patients may even describe breathing difficulties, or they may even describe things like hoarseness or swallowing difficulties. Sometimes patients will present with increases in muscle tension or muscle tremors. What do Scooby and Shaggy look like when they see the ghosts? They're shaking, right? I mean, like they've got all that tension. So increased muscle tension is not uncommon. Increased changes in increased sort of tremors or twitches are not uncommon. Sometimes one of the things that we'll think about are GI symptoms, which are very common, dysautonomia. So it's not uncommon for patients to feel like they have nausea or lack of appetite, that kind of, or like gnawing feeling that you might get in your stomach when you're going up a roller coaster or right before you give a big talk or take a big test, for example. And sometimes it can even lead to things like pelvic floor dysfunction, secondary to things like the muscle tension we see. So you might see even things like constipation, diarrhea, and there may be even some association with some of the GI and digestive and abdominal pain symptoms that we sometimes see in long COVID patients. The other things that I sometimes see are skin tolerance or skin color changes and changes in temperature tolerance. One of the things that I think about in sympathetic hyperactivity, central vasodilation and peripheral vasoconstriction. So that almost becomes like that Katy Perry song where you're hot and you're cold at the same time. Your hands can be cold and clammy. but at the same time, a patient might feel flushed and sweaty. And that's oftentimes a description that I've gotten from patients. And then the other thing that you might see, so those are some of the things that I might see in sort of a dysautonomia or in a patient who's struggling with post-COVID dysautonomia. While some of that is going to be, like the orthostatic tachycardia or the lightheadedness upon standing, it can go much farther than that. And there are other things that we might see in response. Now, in terms of management of post-COVID dysautonomia, there are a couple of non-pharmacologic tools that I use as kind of a baseline to address that. And some of these things, if it's orthostatic in nature, I oftentimes will talk about things like salt and fluid. Ideally, if the patient does not already have hypertension, if they can liberalize their salt intake, that is often helpful. And if they can liberalize their fluid intake, if they don't have a contraindication to taking in additional fluids such as heart failure, that would be that's often an ideal thing. I often joke with some of my patients that they're some of the few people that go to the doctor and get told to eat bacon. Why? Because it's salty, it's got lots of protein, it's going to help with that salt and fluid retention. So, patients often I sometimes get a little bit of a chuckle from patients when I talk about that. Another thing that I think is really helpful is compression for some of these patients. And the biggest thing that I think about with compression is that oftentimes the compression stockings that we'll get only go up to your knees. And compression stockings, by and large, are only as good as the vessels that they're compressing. And the smaller and unfortunately, the blood vessels in your lower legs below the knees aren't really big enough to improve venous return that much. So I'll often talk about thigh-high compression stockings, and I will sometimes talk about things like biker shorts, Spanx, or Skims, or abdominal binders with patients because it will help with compression of bigger blood vessels that will improve venous return, decrease some of that orthostatic tachycardia. Strengthening exercises, if tolerated and if they do not cause crashes, and want to really emphasize that, say we cannot precipitate a crash here, but can be helpful because muscles are basically the compression stockings you carry around with you. They squeeze your blood vessels, they improve your venous return. Other things that I find are very, very helpful from a dysautonomic perspective, breath work can be incredibly helpful. I'm a huge fan of deep breathing exercises, boxed breathing, which can help to kind of bring or stimulate the parasympathetic nervous system and kind of get the body out of fight or flight a little bit. So I oftentimes will talk with patients about box breathing or different breathing exercises that they can do. Biofeedback, if it's available, is a great option. The thought process is basically you're wearing sensors that are basically whether or not that are reading either your heart rate variability or their neurofeedback sensors that are reading each brain waves that are sort of telling you or that are sort of giving signals whether or not you're in fight or flight or whether or not you're more sympathetically activated. And then basically you're getting that immediate feedback. You get coaching in terms of meditation, mindfulness exercises, deep breathing exercises that can help to get you out of fight or flight. And over time, you learn kind of what it feels like to be in dysautonomia and how to get yourself out of it naturally. Another thing that I'm a big fan of is vagal nerve stimulation. There is some school of thought that vagus nerve hypofunction, and so the vagus nerve is one of the major nerves in the parasympathetic nervous system. And that vagus nerve hypofunction may mediate some of what we're seeing in this long COVID sort of dysautonomia. And so gentle, non-painful electrical stimulation to the vagus nerve may be helpful. Another thing that I'm a big fan of is acupuncture, which in the right context can also stimulate parasympathetic function. The big thing that you need to do is make sure that you have a good acupuncturist and be very open and honest about what you're struggling with, because different acupuncturists may address dysautonomia or other long COVID symptoms by using different acupoints. So what you tell your acupuncturist will change what your acupuncturist might be doing.
This is just amazing information. First of all, thank you for explaining the autonomic dysfunction, dysautonomia so well and describing so many different symptoms that it entails. I want to touch upon a couple of things that you said. You talked about vagal nerve stimulation, and as of now, we just have one device which is FDA approved for vagal nerve stimulation, but that is in the context of chronic migraines. It's not approved for this, so it has to be done in and still it is being studied, and there is conversation in Recover as well, to understand these devices. The other thing that you talked about is abdominal compression with like biker socks and such, and liberalizing salt intake. So I think that is very important for us to know. Michael, I want you to please talk about some pharmaceutical management for dysautonomia. I know that I have lots of colleagues on this call, especially some folks who see uh, teens, adolescents, in whom dysautonomia can present as a separate entity very commonly. Uh, when do you consider something like ivabradine? Or do you consider it? Do you prescribe it? And when do you consider beta blockers?
I do. So the first sort of thought process is if I think that a patient has significant dysautonomic symptoms, and I think that they may result or they may benefit from a medication that blunts their sympathetic sort of response, I do prescribe. Beta blockers are a medication that that I have seen used, and they can be effective in the right context. The challenge with beta blockers is that beta blockers often come with concomitant fatigue. Um, and oftentimes, patients who struggle with dysautonomia from long COVID are also struggling with fatigue. I do write for, in some cases, propranolol or metoprolol. I always start at very low doses. So if you're going to start with metoprolol, start at like 25 milligrams XL, maybe even 12.5 milligrams X, or 12.5 milligrams XL. If you're going to do propranolol, honestly, I start at 10 milligrams, and then I just walk the way, or I walk it up to about 60 milligrams extended release. So I'll go 10 milligrams, then 10 milligrams twice daily, then 10 milligrams 3 times a day if they can, then up to 20 milligrams 3 times a day, and then up to 60 milligrams a day. So those can be options. I tend to be a little bit cautious with those because of the fatigue. I am a big fan of guanfacine and prazosin in some cases to help to blunt the sympathetic axis. One of the things that I find that is helpful with these medications is that they can be taken later in the evening, and they can maybe help with sleep. And so there can be sort of a sleep aid kind of component to that. There was a very small study, I think, out of Yale that looked at using guanfacine in conjunction with N-acetylcysteine, 600 milligrams daily, as sort of a treatment for long COVID. The other thing that I love about guanfacine is that it's FDA approved for brain fog, so it is often my go-to. It is one of the few medicines that will help with brain fog, but it doesn't rev up your sympathetic nervous system as stimulants might. Guanfacine will actually help to bring that down. Now, the challenge with guanfacine and with prazosin is that they both decrease your blood pressure. While the blood pressure decreases are modest, the reality is that oftentimes patients are already kind of borderline low on their blood pressures. They're already 100 over 60 or 90 over 60. And that little bit or that little drop that you're going to get from those medications is going to drop them, and they are not going to be able to or even further, and they're not going to be able to tolerate it. In those cases, that's when I reach for ivabradine. Ivabradine is a funny channel blocker. It can be used to sort of decrease heart rate, but it does not necessarily decrease blood pressure quite as much. It's more of the issue that you can run into with ivabradine is cost and availability. What I will say though is that cost plus drugs, and so one of those that Mark Cuban pharmacy I have recently found actually tends to have it for a relatively affordable price. So I have oftentimes talked to patients about that. But those are a couple of options. So beta blockers, guanfacine, prazosin. I would say honestly that's probably my personal first line. Um, Ivabradine would be sort of my next line for somebody who's not tolerating it because of blood pressure. In some situations, I will use pyridostigmine or mestinon, which is an acetylcholinesterase receptor blocker, which I think you can start with 30 milligrams twice daily and then go up to 60 milligrams twice daily. Excuse me. And then that actually has the benefit of kind of having some effects on decreasing sort of like on or decrease or like improving dysautonomia by decreasing the sympathetic response while also increasing blood pressure. So it's another option that's sort of out there. I personally am more of a guanfacine and diabetic guy though.
Excellent. This is such good, very comprehensive, very concise information that, that very precise information that we can all use as primary care physicians. And at this time, I just want to put in a plug for the RECOVER trials that are going on. And there is a JAK2 inhibitor which is being studied now. And the trial is actually active in Seattle out of Swedish as well. And we have invited the PI who will be coming for our next podcast to talk about that. So we will, they are enrolling now for the JAK2 inhibitor, which is showing some promise. Is that, Michael, is that what you have heard about it?
The Baricitinib, or are you referring to
Yeah,
Baricitinib?
baricitinib. Yes, yes,
So, I mean, I think it's certainly a very promising medication. I personally don't have a ton of experience with it.
yeah.
I've heard very good things about it, so I'm excited to see what happens with the medication. That being said, it's not something I've prescribed yet, for a variety of
Yes,
different reasons, one of them just being sort of accessibility of the medication.
exactly, exactly. Thank you for that.
So we've talked a little bit about some lifestyle modifications and pacing, and I was just wondering if there are any other kind of lifestyle modifications, and specifically any things that your patients do with their diet that can help kind of overall with their condition.
So there's no one sort of magic bullet diet, I would say, for long COVID. So a couple of things that I think about globally with diet. The first thing is that if there is a micronutrient deficiency, I will tend to try and supplement it. So if somebody has a vitamin D deficiency, if somebody has an iron deficiency, and oftentimes I actually think about trying to get the iron closer to 70 to 100, more so than just getting it within normal range. Here, like at my home institution, one of the challenges is that iron or ferritin reads as normal, like into the single digits. So we oftentimes have quote unquote normal ferritins, even though your ferritin might be 30 and you might benefit from iron supplementation. So iron supplementation is a big one, considering vitamin D or B12 supplementation if levels are low, I think is reasonable. In terms of diet, one of the things that I think about is generally sort of an anti-inflammatory, sort of nutrient-dense diet. And I think about the Mediterranean framework as sort of a very reasonable sort of approach here. So just sort of eating so something that's more plant-based, eat food, not too much, mostly plants. Kind of keeping kind of keeping sort of Mediterranean principles can be helpful for many folks. One thing that I will kind of call out is that many patients will have a number of different allergic symptoms, and there is some thought that mast cell dysfunction may be related to symptom or may be related to long COVID symptoms. If a patient is telling me that they have significant kind of hives or food intolerances or medication intolerances or side effects, I might also consider a low histamine diet as well. The one thing that I do sort of exercise a little bit of caution with is that often where I try not to restrict diets too much, and I try to, and part of the reason for that is just sort of the nutritional implications of restricting a diet, but B, also keeping a lot of different dietary recommendations in your mind is a lot of work, and that can result in cognitive fatigue, and that takes energy away from the other things that you may want to do in the day. So that's another thing that I'm also cognitive of. One other thing that I want to shout out when we're sort of talking about diets, probiotics. I am a big fan of probiotics. There are some emerging data that probiotics may have an anti-inflammatory effect. I personally am a fan of eating your probiotics through fermented foods as opposed to taking a probiotic supplement because I think you get greater diversity of probiotic strains. So oftentimes I will just talk with patients about eating a serving or two of a fermented food or something with active cultures in a day, whether that's kimchi, whether that's natto, whether that's kefir, whether that's kombucha. I've gotten to the point where I have like kefir grants that I'll recommend for folks at the grocery store. But those are things that I will often encourage folks to do as well.
So, Michael, anti-inflammatory diet, we talk about this a lot. We tell patients to do this. Specifically, I put in a blanket statement, limit non-plant-based, like animal-based foods. Of course, vitamin D, vitamin B12, especially if they are deficient, we can ask patients to to replace that. I mean, to replace those with supplements. Uh, Michael, this is across the board for all for all phenotypes, like patients presenting with chronic fatigue or with brain fog or with dysautonomia kind of picture. Um, so, we often have patients who come to us. You mentioned acupuncture, which is great, and there is reported benefit from acupuncture not only with dysautonomia but also arthralgia, multiple joint pains, and myalgia as well. But then there are some other gray zone treatments, which I call them gray zone because I don't know enough about them. I have many patients who ask me about hyperbaric oxygen treatment, some infusions. A couple of days ago, this patient came to me and talked to me about peptides. What about these therapies? Can you shed some light on these therapies? Is there any evidence? Are they evidence based? And what are your views about them?
So I think that you're getting to a really, really important point. I mean, long COVID is in many ways an exercise in medical uncertainty. It's a condition that has not existed or that we have not been aware of for a very long period of time. We don't have large scale randomized controlled trials for many of the interventions that we're sort of discussing. And oftentimes, one of the things that is happening is that patients will come with other sort of things that they may have heard may be helpful, or other sort of therapies that they've discussed. I mean, as an example, I've had patients who have asked me about plasmapheresis. I've had patients who have asked me about triple anticoagulant therapy, for example. And honestly, the first overarching question that I think about when I think about risks and benefits of therapies that I may not be as familiar with and that may not have a ton of evidence is it safe? You know, is this a safe thing for people to do? And so, in order to sort of think about that, I walk through sort of a potential risk benefit analysis. What are the benefits that you may be anticipated to get from this medication or from this treatment? And what are the risks? I have an acronym that I use, TMI, and that stands for toxicities, medication intolerances, and or medication interactions and intolerances. So the toxicities, these are things like, could you develop, or what is your risk of developing a liver, or liver dysfunction, or developing renal dysfunction, or developing something, or another major toxicity, honestly, which in this case is actually financial toxicity, because these are really, really expensive these are some really, really expensive interventions sometimes, and without a ton of evidence, and they can be quite expensive for patients. Medication interactions. Is it going to interact with the other things that you're taking? Or potentially, could it interact with something that could result in or that could provide you benefit? To give you sort of an example of this, I know that there are some trials and some folks who have asked me about rapamycin for long COVID. One of the challenges with rapamycin is that rapamycin I actually found interacts with guanfacine. And guanfacine is one of my favorite medicines for long COVID. So if somebody's taking guanfacine and then they want to get on rapamycin, we have a decision to make. Intolerances and side effects are sort of the other thing. I mean, all of the, or like, everything comes with a risk of side effects. What is the risk for that specific thing? So I think that really the question is it safe? The next question that I always ask is it feasible? And then the analogy that I use for that, or the acronym that I use for that is actually CAP. And that's cost, availability, and purity. How much is it going to cost you? Is it going to work within sort of your budget? Availability, can you even get it? And purity is, I think, important, particularly when we're talking about supplements, because one of the challenges we run into with supplements in particular is the risk that while you may be getting the supplement itself, you may also be getting other things that you weren't bargaining for, like heavy metal or lead or things like that. I think that there was a study out there that I think 60% of protein powders have some form of lead in them, which was slightly disconcerting when I read it. So we need to make sure that you're not getting something in that supplement that's working at cross purposes to what your end goal is. And then I think that the other thing is that, or so I think that we're walking, or so for me, it's important for me to walk through sort of the benefits, the risk, and then the feasibility of different interventions. When you're talking about things like peptides, for example, the challenge is accessibility and cost. What is the cost? Or they're going to be very expensive. Availability is extremely limited, and purity is going to be questionable in those cases. And so I usually do not recommend peptides to patients. Hyperbaric oxygen therapy. The challenge with hyperbaric oxygen therapy is that hyperbaric oxygen therapy is about $3,000 to I think $5,000 per out-of-pocket session, which can make it quite challenging for some to pursue. And there may be risks that might be associated with that. For example, if you were to have a history of something like a pneumothorax or something like that. Now, if you're able to sort of go through and say, hey, I'm not so worried about the risks, or the risks are low, and then the benefits may outweigh the risks, then I think that sometimes there may be a little bit of a gray area in which you might be able to discuss some of these therapies with patients. But there are a few that I've basically kind of said are kind of off limits. Peptides being one of them because of the availability and the purity question. I would say triple anticoagulant therapy is another one that I get very worried about because of the bleeding risk. I think plasmapheresis is another one that I get extremely concerned about. And then I think in general, anything that involves sort of an implantable device is something that I tell patients to exercise extreme caution with and usually end up recommending against.
Very, very important information. And Michael, I have a question in the audience. Is there a resource link that you like to refer patients to for anti-inflammatory diet? Is there a link that people can use?
So personally, I just use sort of standard Mediterranean diet recommendations. And so I think here we have like a handout that, like an institutional handout that kind of goes through the Mediterranean diet. And I will usually use that for patients. It's not the fanciest thing, but it does work for me. So,
Yeah, and
but
I don't know if you've, Michael, if you've seen that, but there is the Bateman Horn Center. They have a ton of information on their website as well, and people can access that. Uh, Over to Nick for the next question.
Yeah, so I think as we're kind of wrapping up here, I was just curious, uh, kind of where you see long COVID care going and kind of what you're most excited about coming into the future, and maybe what areas you think deserve maybe more attention or the most attention over the next couple of years.
yeah, so I think one of the things that I'm really excited about is phenotyping long COVID. And I think that, the challenge with long COVID is that it's a very heterogeneous condition. I can see 10 different patients with long COVID. They can have 10 completely different presentations. And I think that we are finding, though, that there are certain phenotypes that are more common. And right now, I sort of think about that paradigm as sort of more of a symptom-driven phenotype. Like I will think about patients who maybe struggle more with fatigue, for example, or patients who struggle more with dysautonomia type symptoms. I am excited to see how we are going to phenotype patients moving forward and how phenotyping patients is going to be able to direct care. Ideally, it would be really cool if there was some kind of a biomarker. or if there was some kind of a scan where I could say, I can get this level, and based on X, Y, or Z level, I can predict that you will have a better response to X, Y, or Z medication or therapy. Um, I think that that's an incredibly exciting opportunity. I'm really excited also by the possibility of sort of immunomodulatory therapies moving forward. I think baricitinib has a ton of promise. I'm very excited, or I'm very intrigued by kind of the possibility of things like IVIG, for example, which I know Recover is studying for some patients with dysautonomia. Potentially the role of things like rapamycin down the line, for example, or low dose rapamycin as an option for patients who are struggling with significant fatigue and post exertional malaise. I'm also really excited about the possibility of gut-brain axis sort of intervention. So things like microbiome, as we learn more about the microbiome, can we find different ways in which we can more precisely make dietary recommendations for folks? Or can we say you can benefit more from taking X, Y, or Z supplement, or by eating more of this fermented food, and that may help your symptoms? Very excited by that. Then I think, or then I think wearables are another big part. I think we're starting to see some of that with biofeedback and neurofeedback. There are now devices that you can buy and that you can kind of bring home with you. For vagal nerve stimulation, there's a transauricular device you can buy over the counter. It's ear clip that seems to work very well. I'm always really intrigued, and I kind of nerd out on some of the other devices that are out there. I know they don't have a ton of evidence, but the concept of something like an Elamind band, where you can wear a better where you can wear a headband that can kind of help to induce sleep by playing a certain frequency is really really cool and really interesting and really exciting. Then finally, I know that one of the things that has been sort of a hotter topic is AI, but I think that where AI can potentially play a role in some of this is that AI, one of the things that AI can do reasonably well is pattern recognition, and we have a lot of heterogeneity here, and there may be patterns that AI may help us to recognize. So a lot of different things that are coming down the pike, a lot of things I'm really excited about. And I mean, honestly, the hope is that, while I don't have smoking gun sort of test or scan, and I don't have like a silver bullet pill for patients right now, hope is that maybe 5, 10 years down the road, we're going to get closer to that where we can say, oh, I can help to phenotype your long COVID this way, and I can help to target your treatment in a way that I think is going to be most effective, like by modulating these pathways. And that I think is where the future is. I'm very excited.
Yeah, so rightly put, we are as biomarkers are being studied and proteomics are being looked into, genomics are being looked into, there is obviously hope for precision medication, but the therapies and strategies that you mentioned, I think are very, very valuable. And I feel that long COVID is one part of the spectrum, but I feel that these fatiguing illnesses and autonomic dysfunction have been around, forever. And this is not the only condition that they are seen in. There are other conditions which cause these. And some of these strategies, I mean, it's high time that we incorporate them into our practices. So thank you very much, Michael, for, such an insightful session. I know that uh, people here are going to walk away with a ton of information. At this point, I invite questions from the audience. If there are any questions, please feel free to ask Dr. Mueller.
And very quickly, before the questions, I just want to thank everyone who filled out the surveys and just ask that everybody fill out that survey one more time, this time selecting post talk. So thank you so much.
And we will continue to, and Michael, if there is thank you very much for putting your email there. And Michael, if there are any handouts or resources that you feel will help physicians, please send them our way and we'll share them with everyone.
Absolutely.
Thank you. And this recording will be available, as Nick mentioned, on the website. Thank you, Michael, for your time today. We appreciate it. I know it's very late where you are, and I know that This has been very, very helpful to all of us. So we really appreciate you. Thank you.
Thank you so much, Nita. It's an honor and a pleasure to be here. And if you have any other questions, just feel free to send me an email.